Welcome to the Hospital Incentive Programs Review and Update, Fiscal Year 2017, Fiscal Year 2019. My name is Veronica and I will be your operator for today's call. At this time, all participants are in a listen-only mode. Later, we will conduct a question and answer session. I will now turn the call over to Ross Gatsky. Ross, you may begin.
Hello, and thank you for your attendance today. We all know the hospitals are working hard in pursuing projects to improve the quality of care. We hope that what you learned today facilitates your efforts. This session is being recorded and will be available in about 2 weeks. The PowerPoint presentation is a WebEx handout, and we will also provide you guys with links later on to let you know how to access those after the webinar. During the presentation, all lines will be muted. If we have time, we will field any questions that you may have at the end of the session. So please make note of any questions that may come up as you listen, or you may present the questions during the presentation using the chat function. This is a Learn All, Teach All webinar. We'd like participants to share. Let's begin by being fully present and engaged. Our presenters today are Donna Modges from Emporia, Michigan, and myself, Ross Gatsky from Medicare in Wisconsin. And with that, we will begin. These are the main objectives for today. We want to help everyone understand the current status and specifications of the hospital value-based purchasing, readmission reduction, and hospital-acquired condition programs, and talk about the tools to understand those incentive programs, as well as identifying techniques for improvement. The first topic we will discuss today is the hospital value-based purchasing program. First, we will briefly discuss the most recent program results from the fiscal year 2017. Incentive payments for the value-based purchasing program, and we're going to call it VBP for short, will be funded for the fiscal year 2017 through a reduction to the base operating diagnosis-related group payment amounts for all discharges for participating hospitals for the fiscal year. The applicable percentage for fiscal year 2017 and subsequent years is 2%. The total amount available for value-based incentive payments must be equal to the total amount of reduced payments for all hospitals in a given fiscal year. The graph on this slide displays the average VBP total performance score for all participating hospitals in each of the 3 states, Michigan, Minnesota, and Wisconsin, for the fiscal year 2017. Briefly, Michigan's total performance score average was about 36.9, Minnesota's was about 46, and Wisconsin's was roughly 44.3. The national average of all participating hospitals in the country was 35.6, so all 3 states' averages eclipsed that of the national average. In regards to payments and reductions for the fiscal year 2017, the estimated diagnosis-related group payments will add up to roughly $1.8 billion. The number of hospitals that will receive a payment will exceed those that face a reduction during this time period, and it is estimated that about 1,600 hospitals will receive a positive payment adjustment, compared to roughly 1,300 hospitals that will receive a payment reduction. The highest performing hospitals in VBP will receive a net increase of more than 4% in the fiscal year 2017, while the lowest performers will receive a net decrease of roughly 2%. So there's a fairly substantial difference monetarily wise between the highest and lowest performers in the VBP program. This pie chart depicts the weighting of each of the 4 domains of the VBP program. Starting with the fiscal year 2018 and moving forward into fiscal year 2019 and beyond, each of the 4 domains carries the same weight at 25%. The main difference for the domains is the name change for one of the domains from experience of care to its new name, person and community engagement. These are the fiscal year 2019 VBP measures, with the performance period beginning this January 1, 2017. From fiscal year 2018, there were not any new measures removed for fiscal year 2019, there was, however, an addition to the clinical care domain, and that is the total hip, total knee arthroplasty complications measure. We will go further into detail about this new measure in upcoming slides. It is also important to note that beginning with the fiscal year 2019, CMS will be collecting data on selected ward non-ICU locations for the CLASI and CAUTI measures. This is to allow all hospitals, including those that do not have ICUs, to use the tools and resources of the CDC's National Healthcare Safety Network, or NHSN, for quality improvement and public reporting efforts, with the rationale that inclusion of data outside the ICU setting represents a more robust reflection of overall organizational performance. Next, we will cover reporting eligibility for the VBP program. To satisfy requirements for clinical care, a hospital must have at least 25 cases for each 30-day mortality measure for a minimum of 2 of the measures. For the person and community engagement domain, a hospital would need at least 100 completed HCAHPS surveys. For the safety domain, the requirements are at least 3 cases for PSI 90 and PCO1, and at least 1 predicted infection and a minimum of at least 3 measures. And finally, to satisfy the efficiency and cost reduction domain, a hospital will need at least 25 total Medicare spending per beneficiary episodes. Altogether, a hospital will need to satisfy eligibility requirements for at least 3 of the 4 domains to receive a total performance score. For an example, if a hospital only has 3 of the domains, each domain will be weighted proportionally at 33% to determine their total performance score. Next, we will briefly go over the new measure for fiscal year 2019, the total hip arthroplasty and/or total knee arthroplasty complications measure. This measure is located within the clinical care domain and estimates a hospital-level risk standardized complication rate associated with elective primary total hip arthroplasty and total knee arthroplasty for patients 65 years and older. Medicare claims is used to identify any of the included complications occurring from the date of index admission to 90 days post-date of the index admission. This is a list of applicable complications for the total hip, total knee arthroplasty measure, and their given time periods after the admission date. The rationale for including this measure into VBP is that both the hip and knee surgeries are rather costly and commonly performed procedures and are thus imperative to address for quality of care. This measure will also provide patients with information that could guide their choices regarding where they seek care for these elective procedures. From the 2017 IPPS final rule, the benchmark performance rates for the total hip, total knee measure was 0.023, with lower rates indicating better performance. I just wanted to remind everyone that we do have numerous VBP resources on our website at lsqin.org. There we have resources for present and future reporting periods, as well as links to educational materials and past webinars. And we also do have a VBP tool that hospitals can use to track their current progress in the VBP program. This tool is titled VBP Worksheets, and it is located on our resources section of our quality reporting page on our LSQN website. And once again, these links will be provided to you at the end of the webinar. Now we will go over some important activities to support improvement in your organization's success in VBP and incentive programs. First, it is important in supporting integration among infection preventionists, finance, and quality staff. Breaking out the work silos and emphasizing strong communication and having shared goals and pursuing HAI quality improvement projects can increase chances for success. Second, it is key to look ahead in terms of your improvement projects and understand that these processes take time to organize, so it can be easy to be caught off guard or feel overwhelmed when trying to implement quality improvement projects if you are not well prepared. Also, remember to watch for new inpatient quality reporting measures, as there are changes that are deployed each year into this program. This is especially important in regards to VBP, in that the new VBP measures are first adopted by the inpatient quality reporting program. So you should be a good spot, your staff should be in a good spot if you're familiar with any of the new IQR measures and already have quality improvement processes ongoing. Fourth, review your claims reports. This can be a difficult and or arduous task to keep up on, but it is helpful for the staff in understanding the measures in depth and also for identifying any trends or opportunities for improvement by reviewing what is happening with your specific patient population. And building community partnerships can also increase your hospital's chances for success. Having strong relationships with providers at different settings, such as outpatient and long-term care, can help fill in any barriers within the care continuum. This is especially significant in regards to Medicare spending per beneficiary and the mortality measures, where the measure addresses patient care across boundaries. Helping your community partners understand the implications can create a stronger and more engaged working relationship. Sixth, making reducing infections a priority. I think everyone is already working hard in this area, but it is important to remember how much of an impact infections have on VBP performance, as well as other intensive programs such as the hospital-acquired condition reduction program. Next, work to create a culture of safety by using surveys on patient safety culture. Hospitals can use these effective assessments to raise staff awareness about patient safety, diagnose and assess the current status of patient safety culture, and identify strengths and areas for patient safety culture improvement. Also, identify the root cause of problems. More times than not, the hospitals that are performing the best are meticulous in identifying every defect and its cause, and are using this as an opportunity for improvement as well as a learning experience. Be action-oriented in that you are looking for your quality improvement system and identifying areas in which you can make significant gains in terms of improvements, while also being more proactive by addressing potential issues before they become problems. And finally, building your system into your orientation program and creating that consistency of quality processes that would generate systematic change. For the next section, we will discuss some key strategies for improvement on specific VBP measures. For the mortality measures, we know by looking at some of the patient-level data that a lot of these instances are end-of-life care. If the patient dies in the hospital or dies 30 days after discharge, even if it is in hospice, they are counted in the mortality measure. So try to address this upstream as much as possible in your community and how you handle this through care planning. Sepsis is a big area of focus, as a large percentage of patients who die in the hospital is related to sepsis. So methods for early identification and treatment are vital here. Also, implementing rapid response teams and making sure that patients and families are aware of the rapid response team and can get in contact with them if need be. Identifying and studying any kind of patient harm that you have result in mortality can help your staff identify any gaps in care in these areas. And understanding some differences between AMI patients and heart failure and pneumonia patients. AMI mortality more likely occurs in the hospital setting, so try to go more upstream and look at your capacity to stabilize those patients to avoid mortality. Heart failure and pneumonia tend to be more chronic care conditions, and thus looking for effective care transitions and support after hospital discharge can improve on those measures. And also in regards to transfers from skilled nursing facilities for instances when a patient has an advanced care plan. Having hospital staff and the patient's family understand the patient's wishes to prevent any unwanted admissions to the hospital. Look for opportunities for how the patient might be managed to be able to stay connected with their plan for advanced care. Next are the overarching strategies to improve the HCAHPS measures. This is an area that many hospitals are setting as a high priority in their organization, considering that these measures are the ones that consumers use to determine how much emphasis a hospital puts on customer service on a variety of levels. The first strategy is to entrench a strong patient safety culture into your organization. This requires effective leadership and teamwork to embed an environment that values consistent and effective safety procedures and policies. Patient family advisory committees incorporate patients into quality improvement efforts and provide valuable insights from the customer's perspective. Also, for resiliency and situational awareness, study how the patients or family members are greeted at your hospital and overall how your staff interacts with them. And finally, create a culture of staff empathy for the patients that walk through your doors. Relating with your patients and showing compassion can go a long way for them during their stay. Moving on to the Medicare Spending per Beneficiary, or MSPB. MSPB has a best practice rate of 0.83, and there's a common misconception that the national median or threshold is a score of 1, but it is actually just under 1 for you to receive a positive performance score within VBP. It's helpful to think of this measure in 3 buckets. The first being before admission, the second during admission, and the third after discharge. By reviewing your MSPB reports, you can develop effective improvement strategies by identifying in which bucket your biggest gaps are, and they may also have the greatest impact on your overall MSPB rate. Finally, the specifications of an MSPB episode itself covers 3 days prior to admission, continues through hospitalization, and ends 30 days after hospital discharge. However, it doesn't always end exactly 30 days after the discharge if the service has not ended by day 30. For example, if a skilled nursing facility was ordered after discharge and the patient stayed there 62 days, the cost for all 62 days will be counted as part of the MSPB episode. Therefore, creating strong partnerships with long-term care facilities that receive many of your patients can help improve patient care and reduce the patient's costs for the MSPB episode. These are some of the measures that will be included into the VBP program in future years. CMS is adding 2 30-day mortality measures, COPD for fiscal year 2021 and coronary artery bypass grafting for fiscal year 2022. Also for fiscal year 2021, CMS is adding 2 new measures to efficiency and cost reduction domain. These measures are risk standardized payments associated with a 30-day episode of care for AMI and heart failure. It is also important to note that beginning with the fiscal year 2021 and moving forward, the cohort for pneumonia will be expanded to include patients with a principal discharge diagnosis of aspiration pneumonia, as well as patients with a principal discharge diagnosis of principal discharge diagnosis of sepsis with a secondary diagnosis of pneumonia present on admission. And just some measures to keep an eye on. Nothing here has been determined by CMS as official measures for future VBP programs, but they may pop up. 3 episode-based cost measures and pneumonia outcome measure are new to the inpatient quality reporting program for the fiscal year 2019. CMS proposed the clinical episode-based measures to supplement MSPB and also support CMS's mission to provide better health care for individuals, better health for populations, and lower costs for health care. So there are some hints that these may be incentivized into programs in the future. Also with sepsis just having such a significant impact and garnering a lot of focus, it wouldn't be surprising if CMS moved on this as well. And finally, there's more emphasis being addressed to care coordination, Not only was the domain changed to person and community engagement, but CMS is also putting more emphasis on improving quality throughout the care continuum. And these are just some resources for more information about the VBP program. And with that, I will pass it on to Donna Moders of MPRO to discuss the Hospital Readmission Reduction Program.
Thank you, Rob. Welcome everybody. I want to apologize ahead of time. I'm still fighting a little bit of a cold, so if I need to cough, I may put you on mute for a moment throughout the presentation. But first, in going over the readmission reduction program, I like to just give a little bit of history and review those for those who are new to the incentive program. So. First, the Affordable Care Act enacted the Readmission Reduction Program back in fiscal year 2013, so it first affected discharges of October 2012. CMS researched the selected conditions and procedures that would affect a significant number of the Medicare population, and the readmission of these conditions did indicate that there was an opportunity for hospitals to improve the quality of care, and therefore it would be a way to incentivize hospitals to reduce their excess readmissions. The readmission program is only for the inpatient prospective payment system hospitals or acute care hospitals. It is not for LTACs, critical access hospitals, IPFs, and other hospitals as such. Unlike VBP, the Readmission Reduction Program is actually more of a penalty program. However, it's similar to VBP in that it affects the DRG reimbursement for a hospital if they are given a penalty for excess readmissions. The penalty reduces the payment for excess readmissions, and the penalty is a 3% maximum at this time. In fiscal year 2013, the penalty was 1%, and it increased by 1% until it reached 3% in 2015. The Readmission Reduction Program does exclude all planned readmissions. I like to give the definition of readmission because it is an admission to an IPPS acute care hospital within 30 days of discharge to the same or another acute IPPS hospital. And the readmission reduction has a performance period, and it is updated each year. It's always 3 years of data. And as you can see for fiscal year 17, the performance period includes July 1st, 2012 through June 30th, 2015. And there is a requirement in order to be eligible for this program to have a minimum of 25 cases or discharges. CMS has established a methodology to calculate the excess readmission ratio for each condition that is used to calculate the readmission payment adjustment. And a hospital's excess readmission ratio, it's a measure of hospital readmission performance compared to the national average. Also established was a policy for the risk adjustment methodology for readmission measures to calculate readmission ratios, including adjustment factors that include risk adjustments such as the patient's demographic characteristics, if they have comorbid conditions, and the patient's frailty. The excess readmission ratio is calculated as the ratio of predicted readmission to expected readmission. The predicted readmission is the number of 30-day readmissions predicted for your hospital based on performance with the observed case mix, and an estimated effect on readmission. This is presented as a rate per 100 discharges and is divided by the number of eligible discharges. So the expected readmission is the number of 30-day readmissions expected for the year for your hospital on the basis of average hospital performance with your hospital's case mix average hospital effect. And the excess readmission ratio for each condition is multiplied times the sum of the base operating DRG payment for that condition and then added together. And the aggregate payment for excess readmissions is actually divided by the aggregate payments for all discharges and then subtracted from 1 to get the readmission adjustment factor. If the readmission adjustment factor is 1, then there's no payment reduction. I should actually go back here, I apologize. And any number between 0.999 and 0.9700 would actually trigger a payment reduction. Hospitals do receive an annual hospital-specific report for readmission reduction program. There's a 30-day review and correction period for hospitals to review their data. The data is actually very good and very detailed, all the way down to patient-level data. So hospitals should take the opportunity to review those during the review and correction period. And also the results of the readmission reduction program are posted on Hospital Compare, and usually during the month of October or about sometime soon after the preview period is over. And on Hospital Compare, they'll include the number of eligible discharges along with the hospital's readmission rate and also confidence interval. So the 30-day readmission conditions, which we haven't talked about yet, are acute myocardial infarction, heart failure, pneumonia, both with aspiration pneumonia as principal or sepsis as a principal with pneumonia present at admission, COPD, a total hip and knee arthroplasty, and CABG. So in 2015, CMS also adopted an extraordinary circumstance exception policy, and they implemented that beginning with fiscal year 16. The hospital must request a waiver, and they have to provide a lot of data to request the exception. The form is available on QualityNet. It has to include things such as the CCN number, hospital name, the CEO or designee, and the reason the hospital is requesting the exception. And the reason has to include exactly which incentive program they're requesting it for, because this form is used for the different incentive programs also. And you have to actually tell them what measures and sufficient quarters, as well as what the extraordinary circumstances are as to why you're requesting the exception. Just more specifics, but you can add pictures, newspaper articles, media, and such. And it must be signed by the CEO. Here's just a table with over the years since the inception of the readmission reduction program. You can see they added measures. They started out just with the 3 AMI, heart failure, pneumonia, and now for fiscal year 2017, it did include CABG and all-cause readmissions, as well as the 30-day pneumonia measure that added to the cohort with the extra diagnoses of the pneumonia for aspiration and sepsis with pneumonia present at admission. and respiratory failure with severe sepsis. And the reason for that was due to the changing trends in the coding practices of pneumonia, and it really did give a more complete picture of the patients, the pneumonia patients in the hospital, and to better compare the hospital's performance. And what we have here, in the past we've given you what the volume of these conditions are in each state, and so this year, this is the third year we've done this, so we have fiscal year 15 through 17, and I just thought I'd show you how the volume, the more patients you have in these conditions, the higher your risk for readmissions. And one thing I do want to point out is this data is only Medicare fee-for-service data, so it's taken from MedPAR and only Medicare fee-for-service. So you can see, typically I know a trend would need like 5 to 7 data points, and these are only 3, but you wouldn't want to wait too long to catch something. So if there was a reason to do a little root cause analysis based on these results statewide, this may be of some assistance. So anyways, you can see that the AMI, the HIPS, knees, COPD, and heart failure in Michigan, the volume has actually gone down a little bit, except for the pneumonia cases, which has risen, but that also is due to the inclusion of the aspiration pneumonia and such. So that's how Michigan looks. Minnesota, again, basically the same. The volume has gone down except for the pneumonia. In Wisconsin, the volume has gone down in all conditions, even the pneumonia, which is interesting. Here we graph the number of excess readmissions and the percentage of excess readmissions for Michigan. So you can see with heart failure, COPD, and the hip knees that the excess readmissions have gone up in fiscal year 17. However, it's interesting that the pneumonia, even with the added volume at risk, has gone down. For Minnesota, the excess readmissions have gone up in heart failure and knees. The COPD has gone down, so those two states are similar with the heart failure and the hips and knees. In Wisconsin, they've had an elevation in the excess readmissions for heart failure, as well as the hips and knees and the COPD. This is like Michigan. So the LSQIN, the Lake Superior Quality Innovation Network, which comprises Michigan, Minnesota, and Wisconsin, again, we do have resources provided on our website, lsqin.org, and there is a fact sheet for the readmission reduction program, which goes over all of the requirements and such that we've discussed here today. There are opportunities for improvement with the readmission reduction program. The top thing that you should do is really review your readmission reduction program every year and make sure that everything is correct. Use it to do root cause analysis and use it to improve maybe your discharge instruction communication. Use the results. Maybe you can work with your case management team closer, or we also have a lot of strategies and tools in our resources in the following slides. This slide is new, and it's on the QualityNet website, and it really is just a nice visual of how the readmission reduction payment adjustment determination is made. So I've given you the link there to go because I know you can't read it from here. It's hard to make that any larger. So, and then with that, here are the two slides with resources. And that is all I have for the readmission reduction program. So I'm going to pass this back to Ross. Thank you.
Thank you, Donna. And for the final portion of today's presentation, we will discuss the Hospital-Acquired Condition, or HAC for short, reduction program. Fiscal year 2017 was the third year of the HAC program, and it is the third incentive CMS program implemented after value-based purchasing and the readmission reduction program. The HAC measures are all inpatient quality reporting measures, and they do overlap with the VBP measures, so there aren't any unique measures that exist exclusively within the HAC program. Similar to VBP, the total score is determined by the summation of weighted domain scores. And finally, just as the readmission reduction program, it is a penalty program only, and there are no monetary incentives, and it is a mandatory program to almost every IPPS acute care hospital. This next slide presents more of a review as it displays the HAC measures by the domain for the fiscal year 2017. Domain 1, which represents 15% of the score, is comprised entirely of the Agency for Healthcare Research and Quality, otherwise known as AHRQ, patient safety indicator scores. NHSN's infection measures make up Domain 2, which carries 85% of the weight of the total HAC score. So the infection measures have significantly more of an impact on the final HAC score than the AHRQ PSI 90 measures. CMS has adopted some changes for fiscal year 2018 and future years for determining the total HAC score. Decile-based scoring was used for previous years, but now CMS is using a Winsorized Z-score to calculate the total HAC score. It's easy to think about this. The Winsorized Z-score method uses a continuous measure score rather than forcing measured results into deciles, such as 90th percentile, 80th percentile, etc., etc. Z-scores represent a hospital's distance from the national mean for a measure in units of standard deviations. This form of scoring is meant to create a more robust determination of performance than what decile scoring could offer. And if you guys have any questions in regards to this, because this might be like just some complicated math problems, but if you guys have any questions about the new scoring system, just feel free to let us know. The Domain 1 score is the total score of the AHRQ PSI 90 measures. For Domain 2, an average of the NHSN infection scores is calculated. Each of these domains is then weighted 15% for Domain 1, 85% for Domain 2, and then those are added to finalize a HAC score. For the HAC program, lower scores indicate better performance, and the cutoff score for fiscal year 2017 was 6.57. So any hospitals with HAC scores over 6.57 would be subject to penalty. For hospitals that will receive a penalty through the HAC program, CMS makes calculations by taking VBP and readmission reduction program penalties and adjustments first. Again, participating hospitals that score in the lowest quartile are subject to a 1% penalty. Fiscal year 2017 HAC scores for all participating hospitals will be displayed on Hospital Compare beginning with this month, December 2016. Scores will be grouped by PSI 90 composite and NHSN measure scores, Domain 1 and 2 scores, as well as a total HAC score for each hospital. Our next three slides will briefly go over total HAC scores for participating hospitals in Michigan, Minnesota, and Wisconsin. The line across the graph depicts the threshold for the HAC score, which was the lowest performing quartile of participating hospitals. Once again, for fiscal year 2017, this threshold was 6.57, and hospitals with HAC scores over 6.57 are subject to the penalty. When we take a glance at Michigan hospitals in this graph, we can see that the vast majority of the hospitals avoided penalty, with 69 out of 95 scoring under the 6.57 threshold. Next, we have the performance scores for Minnesota hospitals, with 43 out of 50 participating hospitals scoring below the HAC threshold. And finally, of the participating Wisconsin hospitals, 54 out of 66 avoided the HAC program penalty. It is important to remember that the penalty threshold is subject to change from year to year. For instance, the first year of the HAC program, which was fiscal year 2015, the threshold was 7.0. And for last year, fiscal year 2016, the threshold was 6.75. So over the first 2 years of the program, the hospitals are performing better in this area, and the HAC scores thresholds are also following suit by getting lower. It remains imperative that hospitals remain diligent in this area to keep pace with other hospitals and avoid the HAC program penalties. And this is just a review of some of the changes from the fiscal year 2018. CMS added 3 PSI measures to the overall composite while removing another. And also, reporting has been expanded to include data from adult, pediatric, and medical ward locations to allow non-ICU facilities to begin reporting. Here are some of the important updates to the HAC program as noted in the fiscal year 2017 IPPS final rule. The first is a set of requirements for newly opened hospitals for CDC and HSN data submissions. Newly opened hospitals who begin their participation with the IQR program are thus required to report to begin submitting HAC data to NHSN within a certain time period. Also, the data requirements have also been clarified for Domain 1 PSI 90 measures. Hospitals must have at least 3 or more eligible discharges for at least one of the component indicators and at least 12 months of data for each PSI 90 measure. Also, Domain 1 performance periods have been adjusted for fiscal year 2018 and fiscal year 2019 to account for the introduction of ICD-10. CMS wanted to avoid having a reporting period that combined both ICD-9 and ICD-10 codes, so they shortened the performance period of fiscal year 2018 to include only ICD-9 codes, and therefore they had to lengthen the performance period for fiscal year 2019 to include only ICD-10 codes. CMS has also adopted the refined PSI 90 composite measure for the fiscal year 2018 payment determination year and beyond. This component measure is more of a weighted average of the 10 PSI 90 component indicators. And once again, it also remains important to remember that going forward, HAC scoring has been changed from a decile-based system to the Windsorized Z-scores. Here are the finalized measures for fiscal year 2019. Once again, there are not a lot of changes from the previous year, and the weighting of the domains remains the same as well. For this slide, we briefly will discuss some important topics determined by CMS in the fiscal year 2017 final rule. So of these 3,200 hospitals that participated in the HAC program, 771, or roughly 24%, scored in the lowest quartile and are thus subject to penalties. The scoring for domains, total HAC scores, and penalty determinations still remains the same. And finally, CMS is looking at other conditions such as malnutrition to add as a HAC category. Their methodology in determining new measures for the program is by monitoring evidence-based guidelines and previously considered measures. So this may be a review of some of you listening, but there are numerous strategies to reduce hospital-acquired conditions. One strategy is to implement a standardized regimen of patient decolonization. This can be very effective in combating certain bacteria, such as MRSA, or MSRA. Also, promoting the appropriate use of antibiotics through an antimicrobial stewardship program can help reduce microbial resistance and decreases the spread of infections caused by multi-drug resistant organisms. And proper cleaning of the workplace can make a big difference in reducing HAIs through sterilization and disinfection. The CDC has a set of recommendations for the proper disinfection and sterilization in healthcare facilities that can be very helpful to hospitals who would like to work on this. And finally, just following through and implementing standard precautions, even ones that may seem as simple, such as hand hygiene, can have a significant impact in reducing infections and thus lowering your hospital HAC score. And looking into the future, CMS may align the conditions measured between the HAC reduction program with the hospital-acquired conditions present on admissions indicator program. Just a reminder that the fact sheets for the HAC reduction program, as well as the ones for VBP and readmission reduction program, are located on our LSQIN website. And this is just a list of other helpful HAC resources. And here's the link on the LSQIN website for the fact sheets that we used for our presentation today. And a reminder, here is a list of LSQIN contacts for those interested in joining our region's care transition work and some other inpatient quality reporting program resources. So with that, we can now open up the lines for any questions that you may have.
Thank you. We will now begin the question and answer session. If you have a question, please press star then 1 on your touch-tone phone. If you wish to be removed from the queue, please press the pound sign or the hash key. There will be a delay before the first question is announced. If you are using a speakerphone, you may need to pick up the handset first before pressing the numbers. Once again, if you have a question, please press star then 1 on your touch-tone phone.
Yeah. And Don and I would like to thank everyone who attended today, and we would strongly advise you, if you could, please fill out the evaluation for the webinar. This provides us with valuable insights on how valuable you thought the information was, and it gives us kind of the framework in creating more educational materials in the future. So if you could take a couple of minutes and answer those questions, it would be greatly appreciated.
I also wanted to just let you know that the slides were mailed out earlier to the participants for today's webinar.
Yeah, and the slides will be available on our website. And there's a link for that, and it's located under the resource section. And the webinar recording will be available on our YouTube page within a couple weeks, and that is located at youtube.com/user/LSQIN, and that is in those links are provided within the chat box. Oh. We do have a question from Kathleen. Since NHSN measures have new baselines and risk models for 2017, okay, we have a couple questions. Since NHS measures have new baselines and risk amounts for 2017, will CMS release new benchmarks and thresholds for VBP? Well, that is a good question, Kathleen. I know they have recently released the new benchmarks and thresholds for performance for VBP for 2017. If you wanted to send me that in an email, or I can get your contact information from the attendance list, I will get back to you on that. And we also have a question from Robin, who, what is the minimum of cases necessary for the total hip and total knee score in VBP? And I would assume that falls under the same minimum amount needed for the other clinical care measures, which I believe is, let me check here. For the eligibility, we need at least 25 cases. But once again, just to make sure, I will look into that further and get you that answered as well. So thank you so much for those questions. It's a complicated program. There's a lot of measures, a lot of specifications, so it's really hard to keep anything straight. Sometimes for us too. With that, do we have any questions in the queue, Veronica?
We have no questions at this time.
Okay. Well, I think if there aren't any other questions, and Donna, I don't know if you had anything you wanted to add. I think we could conclude our webinar today. So, like I said, if you could please take the time to complete the short evaluation. It is very helpful for us, and we appreciate your feedback. The slides will be available on our website at lfqin.org, and the webinar recording will be available on our YouTube page at youtube.com/user/LFQIN. If you have any questions, please feel free to contact us, and our contact information, again, is available on the slides. This concludes our webinar today. We thank you for your attendance, and you may now disconnect.